My name is Kara Rick. I am a graduate student in Arizona State University studying for my Doctor of Nursing Practice, otherwise known as DNP degree. I am specializing in family nurse practitioner. I am also a registered nurse. I have a keen interest in breastfeeding medicine and improving the care provided to mother-baby dyads. Myself, along with Tracy Grady, who is an international board-certified lactation consultant, as well as a registered nurse with a Bachelor of Science in Nursing, will be presenting this module to you. Neither Tracy or I have any disclosures to make. Let's begin. Let's first go over our objectives for this presentation. Our objectives for this module are to identify and assess patients for low milk supply, to recommend proper treatment to improve low milk supply, to describe the use of pharmaceuticals, herbal supplements, and non-pharmaceutical methods to increase milk supply, to identify the role of the International Board Certified Lactation Consultant, otherwise known as an IBCLC, and to describe the IBCLC's role in the treatment and management of low milk supply. It's important to note that low milk supply is one of the most common reasons given for discontinuing breastfeeding. Armed with the proper knowledge we are about to present to you, you can help to preserve breastfeeding relationships between mother-baby dyads and help to troubleshoot issues of low milk supply. Remember, we need to be promoting breastfeeding within our practice. All of us play a very important role in increasing breastfeeding rates and promoting wellness among mother-baby dyads. To get started, let's look at the biological process of milk production. How does a mother's body, after birthing a child, change to start milk production? These next couple of slides are going to give insight into the changes of the breast and hormone changes both during pregnancy and after pregnancy, so that we have a pretty good idea of what goes on within the breast, what goes on within the body, to help the body to start producing milk to feed, for mom to feed her infant. First, let's talk about breast changes during pregnancy. 4 hormones contribute to breast changes during pregnancy: prolactin, estrogen, progesterone, and adrenocorticotropic hormone, otherwise known as ACTH. Prolactin, which is produced in the pituitary gland, contributes to nipple growth during pregnancy. Estrogen helps the ductal system to proliferate and differentiate. Progesterone promotes increased size of the lobes, lobules, and alveoli. ACTH and growth hormone are working synergistically with prolactin and progesterone to promote mammary growth in the woman, otherwise breast changes. The image on the right nicely depicts breast changes during pregnancy. Not all women have marked changes during pregnancy, but it is important that they do note some changes during pregnancy. A woman who reports no changes in their breast during pregnancy is very susceptible to having a low milk supply. We will discuss this more in depth later. The transition from pregnancy to lactation is called lactogenesis. Lactogenesis has 2 stages. Stage 1 occurs mid-pregnancy at about 2 to 3 days postpartum. This involves the breast changes we just noted. Epithelial cells of the alveoli differentiate into secretory cells for milk production. Prolactin stimulates mammary secretory epithelial cells to produce milk. This is the stage where colostrum is produced. Oftentimes, mothers can pump colostrum from their breasts prior to giving birth. Lactogenesis stage 2 occurs about 2 to 5 days after birth of the baby. Lactogenesis stage 2 is triggered by the fall of progesterone levels due to the expulsion of the placenta. If there are retained fragments of the placenta, a woman will not experience the drop in progesterone, and lactogenesis stage 2 will be delayed. There are also other medical causes related to the delay of lactogenesis 2 that we will further discuss. Lactogenesis stage 2 is when copious milk production occurs. Lactogenesis stage 3 is when milk production switches from an endocrine function to an autocrine function. By this, I mean that milk production is dependent on supply and demand and no longer entirely hormone driven. By the time we get to lactogenesis stage 3, mother has a well-established milk supply and hormones are not playing as important a role in the process. I would like to dedicate an entire presentation just to lactogenesis and breast changes during pregnancy and the first 3 weeks of life. What is important to know is whether or not a mother is progressing through the stages of lactogenesis, 1, 2, and 3, and if she is not, how we can determine the causes and come up with a solution. Now that we have a basic understanding of how the body changes to support lactation and nutrition for the baby, let's talk about assessment of the mom and baby to detect issues that may cause low milk supply. Having excellent assessment and detective skills is crucial to being able to diagnose and treat issues related to low milk supply. I have just discussed how breast changes during pregnancy. It is important that providers begin to discuss infant feeding options before the baby is born. This can be done by all types of providers, family practice, obstetrician, or even a pediatric provider if parents come to interview you. Promoting breastfeeding and sending the message that you support breastfeeding is an important message to send mothers, parents, families, everybody. Research shows that mothers are influenced by the perception of their primary care providers related to breastfeeding. Additional research shows that providers who support breastfeeding have patients who are more likely to initiate breastfeeding. And furthermore, research shows that if a provider supports breastfeeding and a mother is on the fence, she's more likely to try and initiate breastfeeding than if she is a provider who either has no commitment towards breastfeeding or does not discuss breastfeeding. So your role in you promoting breastfeeding within your practice is huge. Questions that should be asked to the mother during pregnancy. What feeding options are you considering? Have you breastfed in the past? And what was your experience like? Have you attended a breastfeeding support class? Would you like information to community resources? Referring patients to organizations such as La Leche League and Breastfeeding USA, as well as hospital breastfeeding classes, can help patients to set up support systems and identify community resources before the baby is born. Having a plan in place before the baby is born helps the mother to initiate breastfeeding and also to continue on and support breastfeeding. Mothers and families should know that breastfeeding is not simply putting baby to the breast. While some women that works really, really well, other women find that it can be difficult for them. And knowing that they have a support system in place, knowing that they have either friends or support groups to go to, makes a difference for them. Asking questions that might contribute to future breastfeeding issues, such as, have you ever had surgery on your breast? Breast implants. Have you ever experienced breast damage or injury to your breast tissue? Are you noticing your breast changes during pregnancy? If you recall back to a previous slide where I show the breast changes that occur during pregnancy, mom should be experiencing some of these changes. And if you're in the 3rd trimester of her pregnancy and she's not developing any changes, this is a point where you can intervene and you can start to do some detective work to determine why her breasts aren't changing and if indeed she's going to have trouble with low milk supply in a hospital. All of this information, asking all of these questions, gives some indication as to how breastfeeding initiation and continuation will work. A woman should have a physical exam of her breasts during the 3rd trimester. Looking at the breast, you will want to look for flat or inverted nipples, damage to the breast, and insufficient glandular tissue. The image on the upper left gives you an idea of what a flat or inverted nipple may look like. While flat or inverted nipples should not have a huge impact on breastfeeding, documenting this information and discussing techniques to evert the nipple to help baby to latch can be very helpful. Be mindful that breastfeeding will change the shape of the nipple. Also, for a mother to know that she has flat or inverted nipples might be a good point for her to contact an IBCLC, for her to kind of talk into support groups to see what she can do so that her first breastfeeding experience is not frustrating for her and for baby. The image on the lower left gives you an example of insufficient glandular tissue. This image was taken from an article discussing plastic surgery options for patients that present this way. When this woman were to become pregnant, her breasts may change or they may not change. But having an idea of what insufficient glandular tissue may look like can give you clues to possible breastfeeding difficulties. Say, for example, you see a woman in your clinic and she has insufficient glandular tissue. You're going to want to document and follow this woman all through her entire pregnancy. One, to see if she has breastfeeding changes, and if she does not have, or to see if she has breast changes, and if she does not have breast changes, you're going to want to help her to understand that it may not entirely be possible for her to provide a full milk supply to her baby, because having these discussions prevents letdown, depression, upset later on in the hospital, and people understanding expectations in their role. I will note that seeing insufficient glandular tissue is extremely rare. So the likelihood that you see it is somewhat small, and the likelihood that this causes, or the likelihood overall that this occurs, is very low in contributing to low milk supply. Breasts that have been damaged, surgically altered, or the ones that have not changed during pregnancy or appear to have insufficient glandular tissue may cause difficulty for the breastfeeding dyad. Specifically, in the case of breast damage or breast surgery, you want to look for a lateral incision near the fourth intercostal nerve. If you look at the images on the right, you will see where the fourth intercostal nerve is located in relation to the breast, as well as the importance of this nerve and how it affects the nipple and the areola. An incision in this area may indicate severed innervation of the nipple and areola and cause breastfeeding to be difficult. Also, you will want to examine any surgery involving the nipple and the areola. Oftentimes with breast reduction surgery, when there has been an incision of the areolar margin, that can interfere with milk production. It is important to document all of your assessment and provide the woman with the knowledge she needs to help her prepare for breastfeeding. Just because a woman has breast damage, surgical alteration of her breasts, or does not experience breast changes does not mean she will have difficulty breastfeeding. This does mean that we should be vigilant and we should follow up care with this mother and have a care plan in place so that she knows what she needs to do, what her options are, who she can contact, and who's going to be there to help her. Once the baby is born, we need to do a postpartum assessment. Some of this will be done in the hospital, some of this will be done in the clinic. It's important for both the obstetrician and the pediatrician and the family practitioner to check to see how breastfeeding is going. This is a community job within the healthcare community. All of us play a role in promoting and supporting breastfeeding. During this time is when you will want to start to look at possible clues or reasons for milk supply. Questions to consider asking mom. How was the birth? Did you have any difficulty, cesarean section, prolonged labor? How is breastfeeding going? Are you experiencing sore nipples? Is baby latching on well? How are you feeling about breastfeeding? Has your milk supply come in? Is baby having enough wet diapers? Does baby appear satiated? Are you experiencing any nipple pain? How is baby at the breast? Fussy, happy, frustrated? How are you feeling overall? Are you getting enough rest? Are you able to sleep? Are you feeling good about your relationship with breastfeeding and with your baby and even with your spouse or partner? Do you have any concerns? Answers to these questions will give some insight as to the breastfeeding relationship. If the birth was difficult, you may note it in lactogenesis too. If mom is experiencing nipple pain, you may consider examining the latch of the baby. If baby is fussy at the breast, you may consider supply issues. We will discuss troubleshooting and resolving these issues in a bit. You will want to physically assess both the breast and the mouth of the baby, especially if you suspect a low supply issue. Things to look for: tongue tie, which is more thoroughly covered in another module, but doing an oral assessment on the baby can give a lot of information as to how breastfeeding relationship is going. I would highly suggest you watch the tongue tie module to get an idea of how to do a thorough oral assessment on baby, because this information can be invaluable. Engorgement and milk stasis of the breast. A visual exam of the breast looking for similar things we noted in the prenatal assessment: nipple flatness, inversion, retraction, damage to the breast or nipple, possible damage near the fourth intercostal nerve. You will also want to palpate the breast. You will check for the damage to the nipple, cracking or bleeding, or any lumps in the breast, and observe nipple function. On examination of the infant, you will want to look for the tongue tie, as I had noted, which is pictured here. As I had mentioned, there is another module that truly does go more in depth on infant oral anatomy skills. Another thing you're going to want to observe is baby at the breast. So mom putting baby to the breast, listening and observing breastfeeding. Is the areola going into the mouth? Is baby able to stay on to the breast? Is it latched well? What sounds are the baby making during breastfeeding? Do you hear a clicking sound? Do you see baby swallowing milk? Is baby falling asleep at the breast? All of this information is very important, should be assessed, and should be noted. And if you're not entirely sure what to do with this information, you can discuss this with an IBCLC, a doctor in breastfeeding medicine, so that you can help preserve the milk supply and also help this breastfeeding relationship, because mothers truly want help. If a mother is wanting to breastfeed and we are there and we kind of let her down, this can lead to other problems down the road, not just in terms of health problems for baby by introducing formula, but also postpartum depression. One of the biggest areas we see the onset of low milk supply and potential problems with breastfeeding is the delay of the onset of lactogenesis 2. If you recall from the beginning of this talk, lactogenesis 2 occurs within 32 to 96 hours after an infant is born. Some of the causes of delayed lactogenesis 2 are type 1 diabetes and even gestational diabetes and type 2 diabetes. Research by LeMay et al. Tells us that insulin plays a very important role in breastfeeding. Insulin regulates the nutrient delivery to the breast. As the breast begins to transition from lactogenesis 1, where we are producing colostrum, to lactogenesis 2, where we are producing mature milk in copious amounts, there's a dramatic switch on the insulin receptors and its downstream signaling. The switching of the insulin receptors upregulates fat and protein synthesis to create mature milk. If a mother is diabetic or even pre-diabetic and has insulin sensitivity, this process is delayed. It's hypothesized that women who are obese or have polycystic ovarian syndrome have the potential to experience similar issues with insulin sensitivity, resulting in a delay of lactogenesis 2. If a new mother has retained placenta, this directly affects the shift of hormones, allowing for the onset of lactogenesis 2. If the placenta does not completely expel, progesterone and estrogen levels do not drop to allow for the anterior pituitary gland to secrete prolactin to allow for milk production in the breast. Research by Gajardo and Perez and Massilia found that lactogenesis 2 was delayed in women with stressful and long deliveries related to high cortisol levels. They found that as cortisol levels started to decrease, lactogenesis 2 and the production of milk occurred. There are multiple other research articles talking about the delay of lactogenesis 2. I could spend hours and hours talking about the delay of lactogenesis 2. But for the purpose of this presentation, you need to realize that up to 25% of women experience a delay in lactogenesis 2 for various reasons. The following slide will give you some insight as to the multiple factors that result in this delay, and we've already discussed a few. The result of this delay in women the result of this is a delay in breastfeeding, and also women who choose not to breastfeed at all or do not exclusively breastfeed because a bottle is introduced during this period. Simply put, they are not being given the support and education they need to help their milk supply to come in. Just because we see a delay in lactogenesis 2 does not mean a mom can't breastfeed, will not be able to breastfeed. It just means there's a delayed onset. And having this information and knowing that eventually her milk supply will come in, even though it's delayed, is really important, because even if we do have to supplement just a bit, once that milk supply comes in, baby should be at breast, because we know that breastfeeding is a supply and demand relationship. So if we're not removing or draining milk from the breast, the body's not going to continue to make more breast milk. I want to note that it may very well be necessary that we supplement infants whose mothers are not producing milk, as I noted. But it is entirely possible that once milk comes in, these mothers can have an amazing breastfeeding relationship. You just need to be there to support it. It's important for you to know that the reason for lactogenesis 2 is delayed so that you can be prepared for some of these issues. New mothers need support to breastfeed. As a healthcare provider armed with evidence-based knowledge, you can come up with a plan and help mom to exclusively breastfeed her baby. This flowchart does an excellent job of showing the interrelationships among variables that may affect lactogenesis. When lactogenesis is impaired, leading to delayed onset of milk production and or insufficient milk volume, it may be due to a combined result of these factors: mode of delivery, duration or difficulty of labor, medications used in labor, delayed first feed of the infant, and poor infant suck. Although the majority of difficulties with lactogenesis 2 can be resolved given sufficient motivation by the mother and appropriate breastfeeding management, many mothers do not have access to adequate lactation guidance to support and help them. Understanding the intricate dynamic of the breastfeeding diet will help to troubleshoot and support breastfeeding and ensure that a mother is able to develop an adequate milk supply. You as a provider watching this video and understanding the content in this module is huge, because you play a role in helping mother to bring in her milk supply, understand how her body's working, and understand how breastfeeding is working. If you know how breastfeeding works, you can share this with your patients, you can help to reassure them, and you can provide them assistance, and you can come up with a plan. If you're not aware of how breastfeeding works, how the breast works, obviously then you can't have these meaningful conversations. So thank you for watching this module, and thank you for helping mothers. So what can we do as providers? Mothers should continue to bring baby to breast often. Her body will still produce colostrum to feed her baby, which occurred during lactogenesis 1. And colostrum is very nutrient beneficial to baby. There are actually a lot of benefits in colostrum that help the baby establish good gut flora, to help flush out all of the meconium in the gut. Continuing to stimulate the breast and providing the baby with colostrum will help to prevent dehydration, weight loss, and hyperbilirubinemia. In the meantime, if after 72 hours mother's milk has not come in, you need to start doing blood work to look for a cause. Most unfortunately, the breast is the only organ in the body that we do not have a diagnostic tests to troubleshoot problems. This is an area that certainly could use more research. We do have some knowledge and we do have some information, but being able to look at the whole picture is extremely beneficial. And there are some things that we do know. If we have a mom with delayed lactogenesis 2, we will want to do blood work, as I mentioned, if by day 3 she does not have her milk in. If test results show high progestin and estrogen levels, we want to suspect a retained placenta. Blood work may also show hyperthyroidism, and this should be treated, as the hyperactive thyroid can cause low milk supply. Getting blood sugars and insulin under control will help the body to regulate the production of breast milk, as I previously discussed. And helping mom to get rest and adequate nutrition will help to decrease her stress levels to bring in her milk supply. As I talked about the cortisol levels, as the cortisol levels are high, body's not producing the breast milk as we would like, so helping mother to calm down, get some rest, get proper nutrition, recenter herself can be really beneficial to bringing in a milk supply, starting milk supply, and then continuing to develop a great milk supply. During the first days of life, I would caution against giving baby a pacifier. Instead, mom should bring and keep baby at breast to help stimulate milk production. I already sort of talked about supply and demand with breastfeeding, but what we know is that baby continues to stimulate the breast. That allows the breast to send signals to the brain that we need to produce milk to feed our baby, and then the body produces milk to feed the baby. If we're not bringing baby to breast, clearly these signals cannot be sent. Clearly then the body doesn't know to produce more breast milk. You will want to keep a watchful eye on babies whose mothers are having difficulty producing milk. There is a whole other module on the need for formula supplementation that I would highly suggest you watch. I'm not going to go over supplementation here, but I will say that the two concepts go hand in hand. Observing the baby for uric acid in the diaper, decreased output, minimal weight gain, and high bilirubin levels are indicators that mom's milk has not come in, and we need to do a thorough assessment. There needs to be an intervention to help both mom and baby, helping mom to get her milk supply in and produce milk, and helping baby so that they don't experience any negative health conditions. I want to talk a bit more now about how breastfeeding works. Producing milk is a very complex physiological process that involves multiple dimensions. The breaking down of this slide is a more simplistic description of prolactin and oxytocin, but know that multiple other hormones as well as physical and emotional factors go into milk production. We know that breastfeeding works through supply and demand, as I've been talking about. If a baby is draining milk from her mother's breast, either via breastfeeding or the mother is pumping or hand expressing, more milk will be made to keep up with the demand. While it is advisable that mother has a good diet, diet and nutrition are not one of the key factors that affect milk supply. A mother cannot increase her milk supply if she simply ingests more food. Supply and demand is where it's at. So please, with mothers that come in that say, I have low milk supply, do not encourage them just to simply eat more food. While proper nutrition is important, because the nutrition the mother ingests goes into the nutrition of the milk, more food is not going to create more milk. Remember the first part of this module where we discussed lactogenesis. Supply and demand is part of lactogenesis 3. The feedback inhibitor of lactation controls milk synthesis of the milk. If the milk is drained from the breast, this signals the body to make more milk. And the opposite is true. If milk is not being drained from the breast, signals are actually sent to the body to tell it to stop making milk. In the initial stages of lactogenesis 2, we know that we need these signals to be sent so that we can develop a proper milk supply. So supply and demand, putting baby to breast, stimulating the breast, draining the breast, all very important and very necessary. The two images on this slide give you an idea of how supply and demand work. The baby comes to the breast and stimulates the release of the milk. Signals are sent to the mother's brain, specifically the hypothalamus, en route to the pituitary gland. The posterior pituitary gland produces oxytocin, causing milk ejection, and the anterior pituitary gland releases prolactin, causing milk production. problems start to arise when we alter this process, putting babies on a schedule to feed as compared to feeding on demand, introducing supplementation to the system, or even spending a period of time away from baby and or ineffective pumping can alter this process. Babies need to be fed on demand. Babies have no concept of time, meaning that they don't understand what a 2 or 3 hour period is. They understand that their body is hungry and they are seeking nutrients. Especially in the first 6 months of life, they desire to come to the breast to seek nutrition and comfort from mom. When milk is not removed from the breast, production slows down and mom becomes at risk for mastitis and other breast complications. The breastfeeding relationship is actually really cool. To be fed, this sends a message to the breast, this sends a message to the brain. We start to make more milk, we start to feed our baby. When we start to intervene, we start to say, oh no, we only need to, feed every X number of hours, or we need to do things on a schedule. This messes up with the whole process, not only just for baby, but also for mom. So know that breastfeeding is a supply and demand. Know that babies need to be fed on demand, and babies know themselves well. If you know you're hungry, you can feed yourself. If a baby wants to feed, they become fussy. That means put them to breast, give them some breast milk. We know that supplementation can cause problems. If a baby is getting nutrient from another source other than mom, this means that unless the mom is using a supplemental nursing system, which we will discuss a little further in this module, the breasts are not being stimulated, yet baby is getting nutrition. Of course, with everything we've talked about, this is going to lead to decreased milk supply and possibly involution of the breast, because the body thinks that the baby may be weaned or the baby doesn't need breast milk anymore. Similarly, if a mom is pumping in addition to breastfeeding baby, the body may think that it needs to produce more milk, and mom may end up with an oversupply of milk. And this can cause its own set of problems, which I will delve into during this talk. Also, if a mom goes back to work and is pumping her breast, but her breast pump is not effective at removing or draining milk from the breast, as our baby is, this can lead to milk stasis, which is a perceived decrease in demand, which can lead to a decreased supply over time, and also lead to mastitis for mom. So again, going back to all of these factors, if mom needs to pump, make sure that you're counseling her on how to pump correctly, or sending her to an IBCLC that can really assess her pumping skills and teach her hand expression if you're not able to do that within our clinic. Effectively removing milk to feed the baby is necessary if mom cannot be with baby, but also if mom is with baby and she is pumping to create a greater supply, counsel her to know that she may have oversupply issues, and this can lead to just as much of an issue as having low milk supply. Illness in the mom and baby, which causes separation or decreased feedings, can contribute to a decreased milk supply. So what do we do if we encounter a mother who has low milk supply for whatever reason? She comes into our clinic and we see that she has low milk supply. What do? Initial treatment to increase milk supply is to stimulate the breast to make more milk, bringing baby to breast often, pumping, and hand expression. Skin-to-skin contact with baby to facilitate more feedings and stimulate oxytocin release. Encourage mom to perform self-breast massage. There's an excellent video by Maya Bowman that I have linked in the resource section of this module that you can watch to talk about breast massage, and also talk about the benefits of just simply massaging the breast to increase milk supply, to increase milk letdown. You should view this video on your own and encourage your patients to view this video. You will want to encourage and discuss relaxation techniques for mom, as this will help oxytocin release and improve breast drainage. Supplementation should be minimal at best. use of a supplemental nursing system can be extremely beneficial and will be discussed further in this module. You will want to consider further assessment of the situation. You will want to take into consideration the possibility of pregnancy and medication usage as a potential for causing low milk supply. There's another module that I have created that further discusses medication management and the use of birth control during lactation. Oftentimes, providers are not aware of the effects birth control can have on a mother's milk supply. Other medications can have similar effects with milk supply, and arming yourself with this knowledge, knowing medications can cause low milk supply, and specifically knowing that contraceptive medication can cause low milk supply, will play a huge role in being able to diagnose, troubleshoot these issues with low milk supply. We need to make sure that we are treating the underlying conditions. So as I had mentioned previously before, a blood draw to look at hormone levels, specifically prolactin and thyroid levels, are two key areas of exploration to treat if they are off. As I mentioned, hypothyroidism can wreak havoc on a milk supply because the thyroid does play a role in milk production. Sometimes we are looking for an obvious reason. We are looking for so many reasons for a low milk supply that we miss some of the more obvious ones, such as hypothyroidism, which is really easy to treat. We know that normal prolactin levels range from 3 to 30 nanograms per milliliter. If we know through a blood draw that prolactin is low, which per the medical literature is a very rare occurrence, we know that we need to take a more serious approach to help the mother produce milk and help the baby to get nutrition. Trying to find the root cause of a drop in supply will be beneficial to correcting the problem and helping bring the supply back up. In the last part of this module, we will talk about the role of the International Board Certified Lactation Consultant and how you can utilize their help and support in addition to other measures we discuss here to help improve milk supply. When we are talking about low milk supply, of all the things I've covered, you are a detective. You need to be armed with the correct questions to ask, to look for the clues, to solve the mystery, because there usually always is a root cause for why there is a low milk supply. It should not largely be an unknown. I mean, certainly there are going to be times where you come across a case that you are stumped, but there are a lot of providers through the Academy of Breastfeeding Medicine that you can contact to help, and you yourself, armed with the correct information, the correct knowledge, knowing how breast milk production works, can solve a lot of these issues, help preserve that milk supply, help create awesome mother-baby relationships, preserving the breastfeeding dyad. The Academy of Breastfeeding Medicine has devised an excellent protocol for using galactagogues, which are known as a medication that increases milk supply, to augment milk production and the milk secretion in the mother. Knowing when a galactagogue, know that some galactagogues should be used with caution. I'm going to do this one over again. So now I want to delve into research by the Academy of Breastfeeding Medicine. The Academy of Breastfeeding Medicine has devised an excellent protocol for using galactagogues to augment milk production and the secretion of milk in the mother. What is a galactagogue? Galactagogue is a medication, a food, a drink that we give to mom to help increase her milk supply. I want you to know that galactagogues should be used with some caution. Troubleshooting is the main key here to finding low milk supply, and working to preserve the breastfeeding relationship is key. Mothers may need to use galactagogues. Galactagogues may be beneficial in some breastfeeding relationships, but they're not the say-all, end-all, and they should be used with caution and not in all cases. I want to point out that the Academy of Breastfeeding Medicine updates their protocols ever so often, usually every 2 to 3 years. This protocol that I'm presenting here, talking about galactagogues, will be linked in the resource page. I highly recommend that you visit the Academy of Breastfeeding Medicine website protocol page, bookmark it, and utilize it when working and treating mother-baby dyads with a variety of conditions. The Academy of Breastfeeding Medicine has over 20 different protocols on treating mother-baby dyads. All of their protocols are evidence-based and provide the most up-to-date information. Just a couple of notes before I delve into the Academy of Breastfeeding Medicine protocol. First, as a practitioner, you want to support and encourage breastfeeding. This does not mean that you admonish families for not breastfeeding. Rather, meet families where they are at and be honest and forward about the benefits of breast milk and breastfeeding. Each family and mother-baby dyad has their own circumstances and choices to make. Research shows that when providers support and actively promote breastfeeding in their office, patient perception, initiation, and continuation of breastfeeding increases. Be mindful of the message you are projecting to your patients. This doesn't mean that you have to not accept patients who formula feed, not accept formula feeding, but make sure that the message you're sending is very clear, that we support breastfeeding, that breastfeeding is the best choice for babies. You are here to help solve these low milk supply issues. You are here to support the breastfeeding dyad. On a further note about caring for the breastfeeding dyad, there are 2 golden rules for providing care, especially medical care for mother-baby dyad. Rule number 1 is feed the baby. Rule number 2, protect the milk supply. If we as healthcare professionals follow these rules, we will tend to have fewer cases of low milk supply and prevent problems before they start. Remember, we talk about primary prevention. If we are feeding the baby, especially feeding baby from breast, we are stimulating milk supply, chances are we're not going to lead to this case of low milk supply. Also, breastfeeding is primary prevention, and I don't delve into this enough here. This is more in another module, but there are so many benefits to both mom and baby for breastfeeding that are extremely well documented. So let's talk about galactagogues. As I have mentioned, the breast needs to be continued to be stimulated and drained in addition to using a galactagogue. A galactagogue is not a band-aid and should not be used as such. Even if we use a galactagogue, mom needs to be bringing baby to breast, stimulating the breast, draining the breast, removing the milk. So talking about galactagogues and what is a galactagogue and why should we use them and or prescribe them in practice. As I already mentioned, galactagogues are medications or other substances believed to assist initiation, maintenance, or augmentation of the rate of maternal milk synthesis. The Academy of Breastfeeding Medicine provides discussions on both pharmaceutical galactagogues as well as herbal, food, and beverage galactagogues. I'm going to go over the evidence-based research provided and recommendations by the Academy of Breastfeeding Medicine on both the pharmaceutical and non-pharmaceutical galactagogues that are available. The Academy of Breastfeeding Medicine protocol mentions 2 pharmaceutical galactagogues, domperidone and metoclopramide. I want to discuss both of these medications. Domperidone is not FDA approved. I am mentioning it here not only because of the ABM protocol discusses it, but because you may get mothers that come to your clinic seeking this medication. I think it is important to have some background knowledge on this medication in the event that the FDA does move forward with approving this medication in the United States, and also for some general knowledge if you have a mother coming to you seeking this medication and wanting to have this discussion with her. 2 randomized placebo-controlled blind studies have been completed using domperidone. Both studies showed a significant increase in the volume of breast milk expressed. Domperidone is a dopamine antagonist. Domperidone is typically prescribed as 10 milligrams 3 times daily. Patients typically need only take the medication in addition to stimulating the breast by breastfeeding for 2 to 4 weeks to increase their milk supply and go on and have an awesome breastfeeding relationship. A word of caution when using domperidone is that it should not be used in mothers who have a heart condition, and a thorough cardiac workup should be done if this medication is prescribed, as it is associated with an increased risk of ventricular arrhythmias. The second pharmaceutical that has been studied and used to increase milk supply is metoclopramide. This medication has a similar properties to domperidone. It is a dopamine antagonist and prescribed similarly, 10 milligrams orally 3 to 4 times per day. Currently within the literature, there are only 3 low-quality research studies. Results of these studies did not show statistically significant effect on infant weight gain by mothers who use this medication, though research did not directly look at milk production. Research of these studies instead found that milk production was improved from the suggestion and implementation of optimal breastfeeding instructions, feeding on demand, not offering pacifiers, stimulating the breast, and also by counseling for the mother by a lactation consultant. I would advise you to keep up with the current research on pharmaceutical galactagogues, and I would also advise very strongly for the implementation of optimal breastfeeding, as I just mentioned, breastfeeding on demand, having a good latch, having good positioning, and working with an IBCLC to improve latch, possession, and other breastfeeding issues. Oftentimes, just getting somebody in to work with mom, like through an initial consultation with an IBCLC, can go a long, long way in helping mom to boost her milk supply, understanding the dynamics of breastfeeding, understanding how it works. There are many, many herbal galactagogues that patients may seek and buy over the counter. The 2 most common that I'm going to talk about here and that are mentioned in the ABM protocol are fenugreek and milk thistle. Other herbal galactagogues that you may hear about include goat's rue, dandelion, basil, marshmallow root, and many, many others. Most all herbal galactagogues are culturally linked, meaning that cultures have used them throughout time with reported results of increasing milk supply. Unfortunately, there are not many valid and reliable studies that exist that can attest to the benefits of herbal galactagogues. I could spend 2 hours discussing the benefits and herbal properties of multiple herbs as they relate to lactation. But without direct evidence, it makes it difficult to make a steadfast recommendation for a single herb. If a patient strongly feels that an herb is helping them and improving their milk supply, there's little to no harm in continuing its use, given they're not taking other medications and knowing their medication history and knowing their health history. Mothers know their bodies well. Unless there's a foreseeable negative drug interaction, encouraging patients to do what works for them is important. Remember, we are needing the breastfeeding diet from where they are at. And you are certainly able to have conversations with patients about herbal galactagogues and the limited research is available. But again, you want to promote breastfeeding. Breastfeeding on demand, stimulating the breast, draining the breast as often as needed to provide nutrition to the baby. You will find many food and beverages that claim to promote breastfeeding. Oatmeal, the barley component of beer, seaweed, and millet, just to name a few. Just as with herbs, there are unfortunately no studies that support or deny the claim that these handed down recommendations work or do not work. Companies are starting to make what we know as marketing as lactation cookies that claim to increase milk supply. You will see and hear about herbal shakes that promote wellness and increase milk supply. Be cautious in your recommendations and your support. There is some anecdotal evidence suggesting that eating oatmeal does increase milk production. I would certainly say that eating oatmeal is most likely not going to harm anyone, though I would be hesitant to give a steadfast recommendation to patients to constantly eat oatmeal. But again, going back to what's working for mom, if she's been advised to eating oatmeal from her friends or another individual, certainly don't discourage it, but know that the research is not out there to support it one way or another just because research in this area is not occurring. Areas of food and drink galactagogues is an area that is very limited in research and deserves a lot more time dedicated to research to help determine how these galactagogues may or may not work in increasing milk supply. It is important to do a thorough workup of mom to make sure you are not missing any noted problems, as I've previously mentioned. Mothers that are anxious and nervous or even associate breastfeeding with pain, possibly due to sore nipples or past trauma or abuse in their life, may benefit from the use of an antidepressant to help them relax. Stress and anxiety can have huge impediments to forming a strong milk supply and having a good letdown reflex. I'd like to point out here that another module, medication management, talks about the use of antidepressants specifically for postpartum depression, but if you have a concern about prescribing this, know that there is a lot of research and options out there to give moms this sort of medication, and it is completely compatible with breastfeeding. Other considerations, as we touched on, are mothers who are either type 1 diabetic, type 2 diabetic, or pre-diabetic. Some research suggests that mothers who are in these situations and mothers who have polycystic ovarian syndrome benefit from the use of metformin. Metformin works as an androgen blocker and helps increase cells' response to insulin. An indirect result of the metformin is an increase in milk supply. This is why getting blood work done can be so important, instead of just jumping to conclusions or suggesting supplementation right out of the gate. Do your best to troubleshoot the situation and preserve the breastfeeding relationship. Now that we have covered some of the basics of the diagnosis of low milk supply, let's talk about interprofessional collaboration with an international board-certified lactation consultant, otherwise known as an IBCLC. Tracy Grady is an IBCLC that works at a local hospital here in Phoenix, Arizona. She has extensive experience in working with mother-baby pairs within the hospital and working to troubleshoot low milk supply issues.
Hello, I'm Tracy Grady. I'm an RN with a Bachelor of Science degree in nursing, and I'm an IBCLC, which means International Board Certified Lactation Consultant. I've been working with mothers and babies for 32 years, helping them learn to breastfeed. To become an IBCLC, you must take 90 hours of continuing education and have at least 1,000 clinical hours working with mothers and babies before you're even allowed to take the exam. The exam will be given twice a year starting in 2016 and must be taken every 10 years to remain certified. Lactation consultants recertify every 5 years by retaking the exam or proving enough contact hours in education. We work to promote, protect, and support breastfeeding. IBCLCs are governed by the International Board of Lactation Consultant Examiners, who are responsible for making up the test and making sure that it is a good test of people's knowledge. Other organizations to be aware of are ILCA, International Lactation Consultants Association, and USLCA, the United States Lactation Consultants Association. Lactation consultants help mothers with breast conditions. We support moms, show them how to position the baby, help the baby latch correctly. We teach them breast massage, hand expression, and much more. When troubleshooting for low milk supply, we assess that the baby is latched correctly and draining the milk from the breast adequately. We make sure mom is able to position baby to best achieve a good latch, and we encourage feeding on demand for most babies. Moms often have stress that affects how well they do, so we help them problem solve things in their life that can make breastfeeding more easy. And we're going to evaluate that mom is actually having a milk ejection reflex so that milk gets to her baby. All right, stimulating the breast before a feeding or pumping, it can help to massage the breast to kind of, as some people say, loosen up the milk. Massaging the breast can also detach some of the fat globules that are waiting to be pushed into the milk, and that can increase the fat content of the milk. Hand expression is an incredibly wonderful thing for moms to know how to do. They can get the milk flowing, soften their nipples to help baby latch better, and get milk out. In fact, hand expressing along with pumping has been shown to obtain more milk when mom's pumping and help her have a better milk supply. Pumping is an important tool that lactation consultants use to stimulate and protect mom's milk supply. One of our tricks is to supplement a baby at the breast. One of the items we can use is a supplemental nursing system, and you see a picture here of the fancy SNS, and we have other versions such as a feeding tube and syringe and what's called a starter SNS that has one tube that moms can use to put milk or formula into and give their baby food at the breast. The flow of fluid when baby gets extra milk this way helps him to organize his suck and gives milk at the same time he's at the breast. I like this because it's efficient and it is breast-centric. Babies get their feeding at the breast and then mom will pump afterward, but she doesn't have to do a second feeding. Other options may be to finger feed, and that is to take that feeding tube and put it on a finger and allow baby to suck on it. Most of the time babies are able to get their suction going so that they can suck the milk into their mouth by themselves. Occasionally we provide a little pressure, a little extra help to help them along. We're always very cautious to not let the baby be overwhelmed by the flow of fluid. We also teach moms to bottle feed, and we use a method called paced feeding so that baby learns to take the milk and is not overwhelmed by the flow. Types of supplementation, and this is important. We of course would prefer to use mother's own milk, and if that's not available, donor milk from a milk bank. If formula needs to be used, and indeed our first priority is that baby gets fed, ready-to-feed formula is first on the list, then concentrated formula, then powdered formula. And there's a reason for this. First, safety considerations. When handling breast milk, we want to store it properly. The Academy of Breastfeeding Medicine has come up with these guidelines. There's always research going on to make sure that milk is safe, but you can go by these guidelines. For freshly pumped milk, we generally don't leave it at room temperature longer than about 6 hours. Depending on the temperature of the room, that might be a little longer or shorter. I tell moms to put the milk in the refrigerator if they don't know when they're going to feed the milk, or in fact, put it in the freezer if they're not going to feed it that day. In the refrigerator, in clean conditions, milk can be stored safely between 5 and 8 days. Some moms' milk will last longer than others. And if it's in the freezer, depending on whether it's in the refrigerator part or if it's a deep freeze, milk can be stored from 6 to 12 months. Powdered formula is not sterile, and this is important to understand because you may be dealing with a sick baby. NICUs don't use powdered formula anymore because of organisms found in powdered formula causing illness in babies. Tap water versus bottled water. The information from the formula companies and our government suggest boiling any water, cooling it to 158 degrees, then mixing the formula and continuing to cool the formula before feeding the baby. Most parents don't do this. Again, it's good to understand that powdered formula actually has some risks. Additional resources that it will be helpful for you to be aware of and to refer your patients are La Leche League International. La Leche League provides support groups for mothers all over the world. There they'll get encouragement, support, and technical help to help them meet their breastfeeding goals. You can also find good information at their website, LLLI.org, and mothers will get information there as well. I know in our area we have many hospitals that have breastfeeding support groups. please take a moment to find out the groups available to your clients. Breastfeeding USA is another resource for mothers and healthcare providers. Please check out these great resources. Thank you for viewing this module. Please take the post-test and complete the evaluation if you are seeking continuing education hours. Also be sure to watch the videos that may be in the resource area so that you can see demonstrations of some of these products.